Hi friends, welcome to the final part on hypertension. If patient is younger than 55 years, we should start him on ACE inhibitors or beta blockers. If he is more than 55 years, we should start him on calcium channel blocker or diuretic. In step 2, we can add A or B with C or D. In step 3, we can add multiple combinations. Step 4, in resistant hypertension, we should add aldosterone antagonist like spironolactone. So if patient responds to monotherapy, it is good. If he is not responding to monotherapy, we can increase the dose or we can substitute from another class of drug. So choosing the right hypertension drug for your patient is critical. So what are the factors that affect the antihypertensive drug? Cardiovascular risk profile of patients and coexisting disorders and target end organ damage, cost and tolerability, interaction with other drugs. Suppose in hypothyroid patients, we prefer diuretics and ACE inhibitors because this will reduce the fluid accumulation in the body. In case of asthma, preferred drugs are calcium channel blockers and avoided drugs are beta blockers. In case of diabetes, ACE inhibitors, ARB blockers, and calcium channel blockers are preferred. Avoided are diuretics or beta blockers. In case of high cholesterol, preferred drugs are alpha blockers. Other drugs can be used are ACE inhibitors, ARBs. Avoided are beta blockers and diuretics. These will raise the cholesterol. Beta blockers and diuretics have raising of cholesterol property. Elderly patients who can use calcium channel blockers or diuretics. Other drugs are beta blockers, ACE inhibitors. In case of BPH, alpha blockers are preferred drugs. Other drugs are ACE inhibitors, beta blockers. Hypertension in CKD. If creatinine is less than 2, ACE inhibitors and ARBs are contraindicated. ACE inhibitors damage the kidney and there is risk of hyperkalemia with these ACE inhibitors. So we will avoid ACE inhibitors in CKD if creatinine is less than 2. We can give either CCBs, cilnidipine or nifedipine. Even in dialysis, CCBs are safer drugs. Beta blockers like metoprolol or bisoprolol we can give, and in resistant cases, resistant hypertension cases, central alpha 2 agonists, clonidine are used. So how we can follow up this hypertension cases? In stage 1 hypertension, if there is no pharmacological therapy, we can reassess in 3 to 6 months. If we give pharmacological therapy, we will assess in every month. In stage 2 hypertension, non-pharmacological plus BP lowering medication, we can assess in every month. Once BP goal is met, then reassess in 3 to 6 months is advised. So hyperthyroid patients, preferred drugs are beta blockers, next are calcium channel blockers or ACE inhibitors. In heart failure, ACE inhibitors and ARBs with beta blockers and diuretics also given. Symptomatic heart failure with low ejection fraction, if patient has angina, nitrates, amlodipine, nicorandil, antiplatelet treatment, these are preferred. In case of atrial fibrillation, digoxin, warfarin, and amiodarone are preferred. In case of hypertension, spironolactone, hydralazine, or amlodipine is preferred. We have to consider in all cases one ACE inhibitor or beta blocker or ARB blocker or defibrillator. Persisting signs and symptoms of heart failure, even after this treatment, we can add spironolactone or cardiac resynchronization therapy with or without defibrillator and decoxin. In case of intractable heart failure, final choice is transplantation or ventricular assist device. So drugs, diuretics and beta blockers, they reduce HDL cholesterol. So in case of dyslipidemia, these are avoided, and diuretics also reduce glucose tolerance and insulin sensitivity. And alpha blockers reduce total cholesterol and reduce LDL and reduce triglycerides. So these are preferred in case of dyslipidemias. In case of pregnancy, preferred drugs are nifedipine, labetalol, and hydralazine, and methyl-dopa and prazosin. Coronary heart disease, preferred drugs are ACE inhibitors and beta blockers and calcium channel blockers. And congestive heart failure, preferred drugs are ACE inhibitors and beta blockers. Hypertension in case of pregnancy. So after 20 weeks, if BP is more, then it is gestational hypertension. Hypertension with proteinuria is preeclampsia. BP more than 140 systolic and diastolic more than 90 is hypertension in pregnancy. Preeclampsia management. Delivery antihypertensive medications when blood pressure is greater than 160 by 100 using labetalol as first line. Labetalol is most common used drug in pregnancy and followed by metoprolol. Pre-existing or gestational hypertension management, labetalol, methyl-dopa, and long-acting nifedipine can be utilized as long-acting medication. And acute hypertension management, labetalol and immediate release nifedipine and hydralazine can be used. Postpartum hypertension management, BP monitoring should continue due to increased blood volume and diminished afterload reduction, and selection of antihypertensive agents should take into consideration the relative infant dose of individual agents. CCBs can also be given in pregnancy, and ACE inhibitors and ARBs are absolutely contraindicated. And in pregnancy, we should look for secondary hypertension causes. And in case of lactating women, enalapril and labetalol are preferred, and diuretics can be given. And non-thiazide diuretics, loop diuretics can be given. So not thiazide diuretics. Sorry, thiazide diuretics are avoided in case of pregnancy. Loop diuretics can be given. Methyl-dopa 0.5 to 3 gram per dose in 2 divided doses. FDA risk is category B, and labetalol 200 to 1200 milligram per dose into 2 to 3 divided doses, and nifedipine 30 to 120 milligram per dose per day. Slow release, not per dose, per day. Slow release preparation, and hydralazine 50 to 300 milligram per day, 2 to 4 divided doses, and hydrochlorothiazide 2 milligram per day, and beta blockers differs among choices. Hypertensive crisis. So hypertensive crisis include hypertensive urgency. If BP is more than 180 by 120 with no evidence of end organ damage, it is hypertensive urgency. Conditions causing hypertensive urgency is postoperative or preeclampsia, and hypertension in a renal transplant patient, and hypertension in unstable angina. What is our goal? At least 20 to 50% of BP reduction within 6 hours. BP should be lowered. So BP, if it is systolic, once below 160, and if it is diastolic below 100, it should be there. And medications can be oral or sublingual or intravenous. We have to advise admission, and central alpha 2 agonist, clonidine tablet in postoperative conditions, and nifedipine we can give in case of hypertension urgency, and labetalol in case of pregnancy, and captopril and prazosin in case of CKD, and furosemide we can give. We can treat with any oral agents, and observe a patient for 2 to 4 hours to ensure diastolic BP is below 110 millimeter mercury. In case of hypertension emergency, BP is more than 180 by 120 with evidence of end organ damage. Conditions include acute aortic dissection, hypertension encephalopathy, and CVAs, cerebrovascular accident, and subarachnoid hemorrhage, intracerebral hemorrhage, and acute MI or pulmonary edema, and acute renal failure, and eclampsia and papilledema. So hypertensive emergency, stroke symptoms, agitation, and head injuries will be there. Visual disturbance, papilledema, flame hemorrhage, chest pain, myocardial ischemia, back pain in case of aortic dissection, dyspnea in case of pulmonary edema, acute kidney injury in case of kidney problem, and eclampsia and hyperadrenergic agents. What are injectable medication in case of hypertensive emergency? In case of MI, nitroglycerin 0.1 to 0.3 ml infusion pumps can be given, and no bolus dose is given in case of nitroglycerin. Enalapril after delivery, if BP is raised, we can give enalaprilat, and nicardipine neurovascular like hypertensive encephalopathy conditions. Nicardipine can be given. Clonidine in case of neurovascular conditions. Clonidine can be given. Labetalol, neurovascular conditions like acute stroke. Esmolol in case of neurovascular conditions. Bolus can be given in case of labetalol and esmolol, and sodium nitroprusside. Sodium nitroprusside toxic to kidney and liver patients, and phenol toxic to kidney and liver patients. Hydralazine safe in pregnancy, and phenytolamine in pheochromocytoma. Diuretics in case of cardio or neuro we can give. Intracerebral hemorrhage, we can give labetalol 10 to 80 milligram bolus every 10 minutes up to 300 milligrams, 0.5 to 2 milligram per minute in infusion. Contraindications are bradycardia and congestive heart failure and bronchospasm. Esmolol beta 1 receptor antagonist, 0.5 milligram per kg bolus, followed by 50 to 300 microgram per kg per minute, and contraindications same: bradycardia, congestive heart failure, bronchospasm. Nicardipine L-type calcium channel blocker, and 5 to 15 milligram per hour infusion. Severe aortic stenosis is contraindication. Myocardial ischemia is contraindication. Enalaprilat 0.625 mg bolus, followed by 1.25 to 5 milligram every 6 hours. Contraindications are a variable response and sudden fall in blood pressure with high renin states. And phenol dopamine 1 receptor antagonist, and 0.1 to 0.3 microgram per kg per minute. Contraindications are tachycardia, headache and nausea, flushing, and glaucoma, and portal hypertension. And nitroprusside arterial venous vasodilator, 0.25 to 10 microgram per kg per minute. Contraindications are increased intracerebral pressure and variable response, and myocardial ischemia and cyanide toxicity. So NTG relaxes blood vessel walls and dilates coronary arteries and reduces workload of heart. Duration of action is 20 to 30 minutes. Uses in case of angina pectoris, heart failure, or MI. Treatment of heart failure given intravenously at initial dose of 5 to 25 microgram per minute. Buccal tablets in dose of 5 milligram repeated as needed until symptoms are controlled. In chronic heart failure, buccal tablets may be given in dose of 5 to 10 milligram 3 times daily. Treatment of MI used intravenously and to induce hypotension or control hypertension during surgery. The initial dose is 5 to 25 microgram per minute, adjusted according to response. Adverse effects are flushing, dizziness, tachycardia, throbbing headache. Large dose can cause vomiting, restlessness, blurring vision, hypertension, syncope, and rarely cyanosis and methemoglobinemia. And impairment of respiration and bradycardia may ensue. Treatment of adverse effects with oxygen with assisted respiration and may be needed in severe poisoning, and infusion of plasma expanders or suitable electrolyte solution may be required to maintain circulation. If methemoglobinemia occurs, methylthioneum chloride may be given intravenously. In the case of severe poisoning with tablets, the stomach may be emptied by lavas. If large amounts can be ingested, has been ingested within 1 hour, activated charcoal may be used. Thank you.